are moving on to the next system quickly, and that is going to be musculoskeletal system. And this is a case scenario number 4. It's a pretty long one, but I'm sure Miss If will be able to read that for you all. Miss If, please, and thank you.
What had the CPT and high CD10-CM codes reported? A. 22514 M4856XA. B. 22514 22515 by 2 M48.56XA. C. 22514 M4856XA. Z 87.311, Z 98.890, D 22514, 22515 by 2, M48.56XA, Z 87.311, and Z 98.890. Preoperative diagnosis: painful L2 vertebral non-traumatic compression fracture. Post-operative diagnosis: painful L2 vertebral non-traumatic compression fracture. Name of operation: L2 kyphoplasty. Findings preoperatively: she had compression fracture at T11 and L1, for which she previously underwent a kyphoplasty. She initially had very good results, but then developed back pain once again. The repeat MRI 2 weeks later showed that she had fresh high intensity signal changes in the body of L2 and some scalloping of the superior end plates, consistent with a compression fracture at L2. After some preoperative discussion and patient to see if she would get better, she was admitted to the hospital for L2 kyphoplasty, when she did not improve. At surgery, L2 has some scalloping of the superior end plates. Most of the softness was in the back part of the vertebral body. Procedure: the patient was taken to the operating room and placed under general endotracheal anesthesia in a supine position. She was then placed prone on the Jackson table and her back was prepped and draped in the usual sterile fashion using biplane image intensifier. The skin incision sites were marked 0.5% marking with epinephrine was injected initially on the left side. A kyphon trocar was passed down to the superior lateral edge of the pedicle, through the pedicle and into the vertebral body in the usual fashion. The drill was placed into the vertebral body, followed by the kyphon bone tamp in a similar fashion. The same thing was done on the other side. Balloons were inflated uneventfully. The balloons were then deflated and removed, and the cement, where it was in the doggy state, was injected into the two sides in the usual fashion. This was done carefully and sequentially to make sure there was no cement extrusions, which after inspection, there were none. There was a good feel to the vertebral body edges up towards the superior end plate and across the midline. The bone filling devices were removed and the trocars were removed. Prayer was applied, after which the skin was sutured with 4-0 nylon. Band-aids were applied and she was taken to the recovery in stable condition. Complications: there were no complications. Blood loss, minimal blood loss. Counts, sponge and needle counts were correct. Coders, you have some minutes to answer this scenario. Your time starts now.
Okay, Goddess. So I was just looking at your answers. Good try, good participation, Goddess. And yep. Okay, so I was just adjusting my microphone there. Uh, okay, am I audible? Okay, so let's solve the scenario. We have a painful, this is one of the scenario which is an example of that you should not feel overwhelmed by seeing the size of the question or how long is it, the lengthy. If it is a lengthy question, don't feel like it is going to be a difficult one. So this one will show you how easy it is to crack down this scenario. We have a painful L2 vertebral non-traumatic compression fracture. Name of the operation L2 kyphoplasty. The patient had compression fracture at T2 and L1. Previously underwent kyphoplasty. She developed back pain once again, and now she's admitted to the hospital for L2 kyphoplasty under general anesthesia in a supine position. Skin incision performed. A kyphotroch car was passed into the vertebral body. Drill was placed. A drill was placed, and um, in a similar fashion was done on the other side. The balloons were inflated, deflated, removed. Oops. The removed cement, when was in a doughy state, was injected into the two sides as well. So that's all we have in the highlighting the keywords. And what is a vertebral compression fracture? So vertebral compression fracture is caused due to the weakening of the bones due to osteoporosis, trauma, or tumors. And what is the goal for the treatment? So vertebral compression fracture can be treated by two ways. One is a vertebroblasty and second one is by a kyphoplasty. So in a vertebroblasty, it is done to improve the acute pain and function, while a kyphoplasty, it is done to improve the acute pain and function as well as to restore the vertebral height and decrease the severity of spinal deformity. So you will see how it helps in the next slide. So this is another image that will help to understand how the procedure is performed or what is performed during this kyphoplasty procedure. So you can see in the step one, a needle or a trocar or needle, I would say, is inserted into the vertebral body, and there will be a balloon at the tip of this particular needle which is inflated and it will create a space. So this is a fractured vertebral body, and with the help of a balloon, a space has been created, and then through the needle a cement is injected when it is in the Dowie stage, and then later the cement sets so that the vertebra doesn't collapse. So you can see how a fractured vertebral body is treated over here. So that's all what happened in that procedure, in the procedure, long procedure note which you have seen. So is it clear, Codus, the procedure? Okay. Okay, so let's move on to the coding portion. We have highlighted the keywords. We have to document the inventory now. The procedure inventory, we have an L2 kyphoplasty. Diagnosis inventory, we have an L2 vertebral non-traumatic compression fracture. And we have a history of compression fractures at T11 and L1. And status post kyphoplasty, which is a spine surgery. So okay, the principal procedure is going to be kyphoplasty, and principal diagnosis is going to be L2 vertebral non-traumatic compression fracture as well. And let's put our codes over here. Option B, option D is incorrect because both are coding for 125 22514. 22514 is for a percutaneous vertebral augmentation, including cavity creation, fracture reduction, and bone biopsy included when performed using a mechanical device. Example, kyphoplasty. So that's a procedure performed one vertebral body, lumbar. That portion of the question, the code is correct. And also option B and D is coding for 22515 as well. So 22515 is coding for each additional thoracic or lumbar vertebral body. So how many vertebral bodies were treated over here? Let me know the chat code is. Exactly. We had only one vertebral body that was treated. Patient had compression fracture at T11 and L1. That was in past, and that was also treated using kyphoplasty procedure. But currently, she is admitted only for L2 kyphoplasty. That means she is only having a compression fracture at one vertebral body, and that is L2. So, in that, given that, do we have to code for additional thoracic or lumbar vertebral body? No, right? Only one vertebral body is what is treated here. So there is no need to code for 22515. On site, I have eliminated option B and option D quickly within just 1 minute maybe. And now it's between option A and option C, and both are coding for 22514. Correct answer, but option C is coding for some additional diagnosis at 87.311 and Z30 98.890. Those are history codes. So if you remember once again from our first listed code chart, the guideline number 5 that says that do not code any resolved condition, use a history code for the past diagnosis pertinent to the encounter. So we have to use a history code for what all procedure performed. We have a spinal surgery that is performed, which is a kyphoplasty in the past. Also, patient had a vertebral fracture as well. So with that given, option A is not coding for those history code, and option C is coding for history codes, which is at 87.311. So first M48.56X, A is coding for collapsed vertebral body, not elsewhere classified lumbar region. That is correct. Next at 87.311, which is coding for a personal history of healed or other pathologic fracture. Yes, that is coding for the past history of vertebral compression fracture. And Z 98.890, which is also coding for other specified post-procedural state. Since we don't have a specific code for kyphoplasty surgery history, we can code this code Z98.890. So with that given, option A is incorrect, and the correct answer is going to be option C, 22514 M48.56XA, Z87.311, and Z98.890. So I hope the explanation helped, and the graph and the image as well. I love those images. They help me really well to understand the procedure. So scenario number 5, Miss If, reading the scenario number 5 as well. Miss If, please and thank you.
What are the CPT and high CD10 codes reported? A. 23616LT X42.202A. B. 23630LT 20932 X42.202A. C. 23615LT 20932 20900 X42.202A. D. 20630 20932 20900 X42.202A. Operative report. Preoperative diagnosis: comminuted left proximal humerus fracture. Postoperative diagnosis: comminuted left proximal humerus fracture, operative procedure, open treatment of left proximal humerus, anesthesia general, implants, D-Boy Global FX, stem size 10 with a 48 by 15 humeral head. Indications: the patient is a 66-year-old female who sustained a traumatic, severe, comminuted proximal humerus fracture. The risk and benefits of the surgical procedure were discussed. She stated that she understood and desired to proceed. Description of procedure. On the day of the procedure, after obtaining informed consent, the patient was taken to the main operating room where she was prepped and draped in the usual sterile fashion in beach chair position. After administering general anesthesia, standard detopectoral approach was used. The cephalic vein was taken laterally with a deltoid. Dissection was carried out down to the fracture site and the fracture was identified. The fragments were mobilized and the humeral head fragments were removed. Once this was done, the stem was prepared up to a size stem. A trial reduction was carried out with the bitrial stem and implant head. This gave good range of motion with good stability. Sutures down to and through the shaft were placed in key position for closure of the tuberosities. The shaft was prepared and cement was injected into the shaft. The implant was placed. Once the cement was hardened, the head was placed on moss taper and then reduced. A bone graft was placed around the area where the tuberosities were being brought down. The tuberosities were tied down with a suture previously positioned. This gave excellent closure and coverage of the significant motion at the repair site. The wound was thoroughly irrigated. The skin was closed with victory over a drain and staples in the epidermis. A sterile dressing and sling were applied. The patient was taken to recovery in stable condition. There were no immediate complications. Coders, you have some minutes to solve this scenario. Your time starts now.
Okay, coder, so that is a time, and this is a good scenario. This is going to be a teachable moment. I can see mixed responses in the chat, so let's solve this one together. We have preoperative and postoperative diagnosis, both are same. A comminuted left proximal fracture and an open treatment of left proximal humerus performed. Deploy global fracture, stem size of 10 with a 48 into 15 humeral head. That is an implant which was used for this surgery. A traumatic severe comminuted proximal humerus fracture. After administering general anesthesia, dissection was carried out, fracture was identified, humeral head was removed, a trial reduction was performed, deployed trial stem, and the implant head was placed. Shaft was prepared and cement was injected. Implant was placed. Head was also reduced. Bone graft we have. So just so you know that the term comminuted fracture refers to a bone that is broken at least two or more places. So we had a proximal humerus comminuted fracture in the scenario, and the proximal means one which is closest to the point of attachment. So it's somewhere over here in the scenario, and distal means that is away from the point of attachment. So just for your information, so this is what a comminuted fracture looks like, where there will be fracture in more than 2 points, 2 or more points. So coming back to the coding, we have highlighted the keywords, and now let's have a look into the procedure inventory. We have an open treatment of left proximal humerus performed, a depoy stem and implant was used, and a reduction was also performed here. Bone graft were used. In diagnosis inventory, we have comminuted left proximal humerus fracture. So that is going to be your principal diagnosis, and your principal procedure is going to be open treatment of left proximal humerus. And we also have these three steps which is also performed. We have a reduction performed. So you all know that reduction is a kind of a manipulation of a fracture, and that is integral to the fracture treatment, right, coders? So a reduction and a fracture treatment, they are integral to each other. So we are only going to code for a fracture treatment, and we are not going to code for a reduction separately. And also we have a bone graft and a depoy stem and implant. So the bone graft is also going to be an integral to an implant, because the implant is also a type of a graft, right? So if you also read the guidelines for the graft, we can also see similar things about the graft and the implant. So and graft is also a type of implant, and we are also not going to code separately for the graft in the scenario. So bone grafts are usually common in prosthetic placement. We have a depoy stem, which is an implant, which is a prosthetic material which is placed for the fracture treatments. And these bone grafts are common in prosthetic placement, and a matrix is usually provided where a new bone can grow and further stabilize the processes, and they are not coded separately. So that is a key in the scenario. We are not going to code those graft separately. And the CPT code 20932 is coding for 20932 is coding for a graft. Yes, 20932, this is coding for a allograft, and these are the guidelines from the graft section as well, so you can read them, and that will be really helpful. So with that said, we are only going to code for an open treatment of left proximal humerus in this scenario, and that is going to be 23616, which is an open treatment of a prosthetic humeral fracture, which includes internal fixation when performed and includes the repair of tuberosity when performed with the proximal humeral prosthetic replacement. So as I said, the implant was used, and that implant is what they mean by saying it's a prosthetic replacement which was performed. So what is a prosthesis? In a medicine, prosthesis or a prosthetic implant is an artificial device that replaces a missing body part. So that's where a depoy stem and implant which is used. So with that given, option B, option C, and option D all are coding for graft. And as I said, we won't be coding the graft separately in the scenario. And the correct answer is going to be option A, 23616 LTS 42.202A.